I call this meeting of Labor and Industry, Finance and Policy to order. Today is Tuesday, March 12th. First order of business we have is the minutes. And Representative Jordan, did you get a chance to look at the minutes?
Mr. Chair, I did get a chance to look at the minutes for March 5th, and I think they look great, and I would urge members to vote in favor of approving these minutes.
So Representative Jordan moves the minutes from March 5th. All in favor, say aye.
Aye.
Approve, opposed? Ayes have it. First bill we have on the day, and members, we've got a lot of testifiers, and but first bill I have on the amendment, or the thing today is House File 4200, and I'll move House File 4200 to be re-referred to Ways and Means. And I believe we have an author's amendment. And do you want to do that first, or?
Yeah. Basically, it's just to get it in the shape that I would like. It was based on some input from Representative Nadeau and just a technical clarification.
So I'll move the House amendment that H4200A1-1. All in favor of the amendment to put it in the form that the author wants, please say aye.
Aye.
Opposed? The ayes have it. The amendment's adopted. Welcome to the committee, and if you want to explain your bill.
Yep. Thank you so much, Chair. Thank you, committee. The Healthcare Employee Anti-Retaliation and Labor Act, or the HEAL Act, is a labor bill. Whether an employee works in a warehouse, a factory, an office, or a healthcare setting, they are valued members of our labor force and they deserve adequate protections. The Becker Hospital Review recently published an article finding that Minnesota was number 3 in the nation for the search term nurse burnout. In a survey of 2,403 nurses who left their bedside position in the previous year, the most cited reasons for their departure were stress and burnout at 75% and chronic understaffing at 71%. Nurses indicated that the #1 condition needed to return to the bedside was improved staffing. The burnout is similar amongst other care professionals working in a hospital and long-term, I said long-term care setting, but I mean acute care setting. That was the technical clarification we made in the amendment. This bill seeks to address the following trends in Minnesota and how Minnesota cares for patients in acute care settings. Patient safety in Minnesota continues to decline as staffing levels decline. The Department of Health's 2023 Adverse Health Events Report cited 572 preventable events, including falls, medication errors, bed sores, wrong site surgery, and the misuse or malfunction of a medical device. Bed sores made up the vast majority of reported events, and a 2022 study involving nearly 54,000 patients found that staffing levels correlated with bed sores. Numerous studies have connected unsafe staffing with adverse events more broadly. We also know that when staff speak up because they believe that they cannot safely care for a new patient, they experience retaliation. This retaliation includes being sent home, even when the facility is understaffed, not receiving vacation requests, verbal abuse, losing shifts in scheduling, and being put on a challenging schedule with the least preferred shifts. It does not make sense that hospitals send staff home when they have just cited deep concerns over unsafe staffing levels that they believe place patients at risk. To combat these trends, this bill provides protections for direct healthcare workers in acute care settings when advocating for safe patient care. Specifically, it prohibits retaliation against patient care staff when they reasonably believe that accepting a patient assignment would create unnecessary danger to a patient's life, health, or safety. The bill states that this language does not pertain, and I will repeat that because you all might have questions, it does not pertain to patients who are in need of urgent medical care. Emergencies are defined in the bill. Here are 3 scenarios that highlight the types of actions this bill seeks to protect and the types of retaliation patient care staff regularly experience in hospitals and acute care settings. The first example is at a large metro hospital. Nurses started their shift and realized that there were 3 times as many high acuity patients requiring an intense amount of care as had been staffed for. They each separately went to ask for modified assignments, and they quickly realized that the entire nursing staff was in the same situation. The nurses each experienced verbal reprimands and were then sent home. Every single one of them were sent home without pay. The nurses already on shift were forced to stay and continue that work even though they had already worked overnight. Another example, a nurse in Duluth who normally works in medical surgical unit was advised, they said that they did not feel comfortable working in the emergency department because they were not orientated for an emergency department. The emergency department, they work directly, they stabilize urgent or emergent care. It's a totally different type of skill set than someone who, for example, who's in medical surgical unit, cardiac unit. And so this nurse said that they did not have the requisite skill set, and they were disciplined and they were sent home without pay. To anticipate some questions that everyone might have, does this mean that patients will not receive care? The answer is no. This puts the responsibility on management to find patient care solutions instead of continuing to unreasonably burden direct healthcare workers, placing patients in danger. Hospitals have this capability if they choose. For example, hospitals regularly schedule elective surgeries that they do not have staff to care for after surgery. Whether the surgery is a tummy tuck or an open heart surgery, the fact that these are scheduled without sufficient patient care staff for post-surgical care is alarming. We also know that hospitals use benchmarking in order to staff at lower levels in order to maximize margins. Another question you may have, what if hospitals don't have enough staff to meet the need? The Department of Health reports that there are more nurses in Minnesota than ever before, yet they are leaving hospital jobs because of working conditions. We hear the same across all direct healthcare job categories, and you will hear testimony from people who are in multiple roles, patient care staff roles. If hospital administrators do not create safe conditions for workers and patients, we will only see the number of direct healthcare workers fleeing the bedside increase, and this bill provides a solution. Does this mean that workers can decline patients that they do not want to serve out of bias or a desire to avoid difficult patients? This bill explicitly prohibits discrimination through explicit incorporation of the Minnesota Human Rights Act, and it does not prohibit discipline based on performance issues. Rather, it protects workers who are advocating for safe patient care staff or safe patient care. The HEAL Act provides labor protections for patient care for activity that is already covered under whistleblower protections and for nurses under the Nurse Practice Act. Specifically, Minnesota whistleblower laws prohibit retaliation where, quote, the employee in good faith reports a situation in which the quality of healthcare services provided by a healthcare facility, organization, or healthcare provider violates a standard established by federal or state law or a professionally recognized national, clinical, or ethical standard, or potentially places the public at risk of harm. That is already under Minnesota state law, and this bill is intended to protect that specific behavior under labor law. In addition, under the Nurse Practice Act, it explicitly is incorporated into this bill. Nurses are required under their license to avoid, quote, any nursing practice that may create unnecessary danger to a patient's life, health, or safety. Actual injury to a patient need not be established under this clause. The reason that we need labor protections to protect this behavior that's already protected under whistleblower law and the Nurse Practice Act is that these statutes do not provide protection in the moment that is required to protect patient care in the moment. In addition, whistleblower protections involve an extended legal proceeding and provide no immediate or ongoing protections from retaliation. And the Nurse Practice Act provides protections only in the context of a nurse being brought before the Minnesota Board of Nursing for a professional violation. These labor protections are also essential because patient care staff often hesitate to raise concerns about patient care because they fear retaliation. These labor protections will help for more concerns around patient safety to be brought to light. Nurses are coming to the legislature and they're saying that there is a crisis and that the legislature, we have not listened for decades as this crisis has deepened. The status quo is driving patient care staff from the bedside, and there is a broader healthcare workforce shortage that we need these dedicated professionals who have chosen a career in healthcare to remain in these roles. This bill is a labor bill. It's ultimately about empowering workers to advocate for patients. It's about shifting the burden to provide adequate care from those without the power to do it to those who have the most power to make large systemic level changes. And with that long introduction, thank you, I will now turn to testifiers.
And as I call the testifiers up, I just want to point out that my mother was a nurse, started her career at North Memorial, and today would be her birthday. So it's kind of appropriate that this, we're having this bill today, and it wasn't planned that way. Anyway, he didn't know. The first person I have on my list is Chelsea Schaffner. Welcome to the committee. State your name for the record and proceed with your testimony.
My name is Chelsea Shafter. Thank you, Chair and committee members, for the chance to testify this afternoon. My name is Chelsea Shafter, and I'm a registered nurse. I'm here today to speak to you about House File 4200, the Healthcare Employee Anti-Retaliation and Labor Act, and the importance of this bill, not just for nurses, but for healthcare workers in the state of Minnesota. I have experienced the firsthand struggle of making the decision between, do I accept this unsafe assignment, risk patient harm and my nursing license, or do I risk being given a scarlet letter per se by my employer, which could lead to me being retaliated against in a multitude of ways up to termination, thus affecting my livelihood. In both scenarios, it is a lose-lose for the nurse. The employer I worked for promoted a culture of speaking up if you had concerns around safety, as long as it didn't affect their bottom line. I have heard the concern that this bill would lead to unit closures, delays in cares, increased ER boarding, all of which are occurring most days in healthcare facilities across the state without this bill in place. That is because the real fear instilled in us by our employers. As a registered nurse, you are required to wear a lot of hats. With that comes a sort of expertise in problem solving and making it work. Those times where we cannot make it work safely, we need to have the ability to be able to speak up, be heard, and have those situations addressed so we can do our work safely. We are asking for the onus to be placed on the employer to provide nurses with the staffing and resources needed to do their work safely, not just the employer using their judgment to unilaterally decide what is safe and what is not, especially when, per the Minnesota Board of Nursing, it is the responsibility of the nurse to advocate for the best interest of individual patients and provide safe and effective nursing care. We need to promote a culture where nurses can speak up about safety and be met with support from our employers, not retaliation. House File 4200 can do this. Nurses feeling safe and supported to speak up in their workplaces, which in turn creates a safe environment for patients receiving care. This is one way we can retain nurses at the bedside, because when you have more nurses, you have increased patient flow from the emergency departments as there are units open, beds staffed to take patients, and nurses with the resources to provide complete holistic care every patient deserves. Thank you.
Thank you for your testimony. The next person on my list is Ryan Hilmo. And Rachel Ballard is next, so if you be ready. Welcome to the committee. State your name for the record and proceed with your testimony.
Good afternoon, Chair Nelson and committee members. My name is Ryan Hilmo. I'm a registered nurse. I need you to know just how real workplace retaliation is within the hospitals in your state. It's happened to so many nurses in Minnesota where large corporate entities see the bottom line before they ever consider the dying patient. But today I will only tell you about what happened to me personally. Last year, after keeping Nurses at the Bedside Act was no more, I arrived to work at my Alina facility cardiac unit, ready to work another incredibly stressful day, only to discover that the floor was not just stressful, but actually very dangerous. That day, there were 3 times as many highly acute, meaning intense amount of care, patients than what was planned. My assignment was completely unmanageable. I requested for my assignment to be changed so that my patients would get the care that they were hospitalized for, only to find out that every other nurse on the floor was in the same predicament I was. Shuffling our assignments was not an option. The charge nurse agreed that the situation was extremely unsafe for our patients and for the nurses. I would like to remind everyone that medical errors are the 3rd leading cause of death in the U.S. That's a statistic that I don't intend to contribute to, but I very well could have if I would have accepted that assignment. When the charge nurse that day asked if there were any extra nurses in-house that could be spared for the safety of the unit, management said yes, but we could not have the extra nurse. After all of the nurses determined that we could not provide safe care, we repeated our request for safety to management. The chief nursing officer's response was to storm into our break room, call us names, say our nursing judgment was inferior to hers, threaten to terminate us, and to report us to the Board of Nursing. We were told that we were abandoning our patients. Then the entire cardiac unit was dismissed for the day without pay, along with being severely disciplined to boot. All I ask for is the normal amount of stress that comes with taking care of my patients. Now added on top of that, I also have the stress of being unable to speak up for safety due to the very real and ongoing threat of intimidation and retaliation. I'm just one of many nurses that feel like we cannot speak up. No one goes into healthcare to refuse patient care. That only happens in the most extreme and dangerous of conditions. House File 4200 would put the responsibility of patient safety on the company that promises quality care for patients, instead of the staff who are continually required to do more and more with less and have very limited input into these circumstances. I ask that you please support House File 4200. I thank you for your time and consideration today.
Thank you for your testimony. Again, the next person I have is Rachel Ballard, and then Adam Carlin is next. Welcome to the committee. State your name for the record and proceed with your testimony.
Hi, everyone. My name is Rachel Ballard. I'm a registered nurse at Abbott Northwestern Hospital. Good afternoon to you all, Chair Nelson, and the rest of the committee members. Today, hospital management is going to tell you that this legislation will allow caregivers like myself to discriminate against our patients by refusing to care for them based on our racism, homophobia, and other biases. They'll, of course, fail to mention that there is language in the bill which strictly prohibits discrimination. They might also tell you that this bill is really unnecessary because they don't retaliate against their employees anyway. As a union rep for nearly 2,000 nurses who sits in their discipline meetings, I can tell you that could not be further from the truth. The reality is, in the absence of statutory minimums on staffing, it falls on individual nurses like myself to protect our patients from dangers in the clinical setting. When management attempts to give a nurse her sixth unstable and totally dependent patient, it falls on that individual nurse to say, "You need to bring in additional personnel. I'm stretched too thin. One of these patients is going to get hurt." When a nurse who is untrained and uncertified in continuous heart monitoring is ordered to float to a specialized cardiac unit, they must stand up alone and say, "You know that I don't have the training for that specialty. Please find an appropriate nurse so that those patients can get the care that they deserve." Every day, nurses are the last line of defense between patients and the irresponsible choices of hospital management. And when courageous nurses stand up, they face intimidation and discipline, a fact which is supported not only by my anecdotal experience, but by the peer-reviewed literature. Research further shows that when nurses don't report concerns, it's actually the fear of retaliation that's holding them back. And, of course, it's Black and brown healthcare workers who are first to be made an example of and who are most likely to experience retaliation, much more so than their white peers. This, of course, leads to higher rates of burnout and attrition among BIPOC staff. And when they leave, there goes the clinical providers who are at the forefront of correcting disparate outcomes. When workers are too afraid to defend a safe care environment, it is the most vulnerable patients, our BIPOC and transgender patients, our non-English speaking patients, our unhoused patients. These are the most likely to slip through the cracks and experience adverse outcomes. This is your opportunity to protect healthcare workers, especially caregivers of color, from retaliation as we stand up for patient safety. Please pass House File 4200, the HEAL Act, today. Thank you.
Thank you for your testimony. The next person on my list is Adam Carlin, and after that I have Mary Krinke. Welcome to the committee. State your name for the record and proceed with your testimony.
Mr. Chair, my name is Adam Carlin. I'm the Chief Nursing Officer at M Health Fairview Southdale Hospital. I'm a registered nurse, have been a registered nurse for 15 years, including 9 years in varying leadership roles. I'm proud to be a nurse leader, and I'm grateful for the opportunity to represent my colleagues today. To put it simply, I have grave concerns with Section 5 of this bill, which authorizes a hospital nurse to unilaterally refuse with impunity to accept a patient. This provision has the potential to confine some of our most vulnerable patients, including those experiencing mental health crises, to our extremely busy emergency departments. This bill creates significant opportunity for individual bias to determine who receives care in our hospital, bias to which our nursing profession is not immune. As a member of the LGBTQ+ community, I personally am very concerned how this could impact my care or the care of my partner. I am not willing to rely on a statutory mandate that discrimination is not allowed to prevent that from occurring, because we know if it was that easy, we would have already done it. High quality care requires a team, teams that work around the clock to create safe working environments for our patients and their colleagues, teams that work together in delicate balance to determine the best location for patients under our care. This includes the placement of elective procedures, which, to be clear, includes patients such as open heart surgery and cancer surgery. Representative Feist, I don't know the last time a tummy tuck came into the inpatient environment, but if that tummy tuck did have a complication, we would certainly be there as a hospital to help make sure that patient could be cared for. To be clear, hospitals in Minnesota are not interested in retaliating against staff. In fact, most hospitals in Minnesota have a non-retaliation clause in their code of conduct. The authors of this bill have used the term retaliation to describe professional nursing accountability with respect to speaking to a patient refusal. Minnesota already has a strong whistleblower legislation with important protections for individuals who speak up in good faith and report situations in which the quality of healthcare services is in question. Additionally, the Minnesota Vulnerable Adult Act protects healthcare workers in the event that an error occurs while they are providing care in good faith. These existing laws protect nurses that speak up. There is no substantive proof that nurses who raise legitimate patient concerns face retributions from their employers on a widespread basis. In fact, at Fairview, our Safety Always culture requires staff who have questions or concerns to speak up, to practice a questioning attitude, and to communicate clearly when there are issues. Authors of this bill have mistakenly confused retaliation for accountability. And in Section 5, which gives nurses the unilateral authority to refuse patients, this lack of accountability will create serious problems. In closing, it is important for this committee to consider the impact this proposed provision will have on our underserved, marginalized, and vulnerable patients, patients that we care for in our hospitals every day. In an increasingly polarized world, it is not a bridge too far to see this provision used to an extreme, giving people with conscious or unconscious bias the ability to pick and choose their patients. Under this law, a nurse can simply say, "I refuse, and I am unwilling to talk about it until I have representation present." We have an existing whistleblower law. We have existing internal processes and protocols in our hospitals to support safe patient care environments. We will continue to oppose this bill. Our patients deserve a higher level of accountability. Thank you.
Thank you for your testimony. Mary Krinke is my next person, and after that I have Melissa Heising. Welcome to the committee. State your name for the record and proceed.
Mr. Chair and members of the committee, for the record, my name is Mary Krinke, and I'm with the Minnesota Hospital Association. Nurse leaders move care teams around to meet patient needs. Patients are all different, and their care needs can change very quickly. Nurses have different training, expertise, and different work experience. If a nurse refuses to care for a patient, that patient is still there in the hospital bed. The charge nurse would certainly try to find an alternative nurse to care for that patient, but that is not always going to be possible, particularly as the unit has more expertise. If it's a unit that requires an ICU nurse or a pediatric nurse, you just can't move another nurse into that unit. As you all know, several of our hospitals have collective bargaining agreements in place. This patient refusal issue was brought forward in several of the contract negotiations in 2022. Language regarding what is the process for seeking additional help was ratified in several contract agreements. However, the provision allowing a nurse to refuse a patient assignment was not adopted in the 2022 contracts. The Twin City contracts are up again in 2025. And this may be an issue once again in those negotiations. It should not be put into law. No other care team members, including physicians, can refuse to care for a patient, particularly one that has already been admitted to the hospital. I would like to close today with a few pieces of information that address some of the comments that were made already. If you all Google any quality scores of states around the country, Minnesota is always in the top 5. I'm concerned by some of the comments that were made today about the quality of care delivered by Minnesota hospitals. Number 2, I would urge all of you all to read a copy of the Board of Nursing, not the Minnesota Hospital, the Board of Nursing's Workforce Data Report. There's a lot of really good information in that report. And you know what? Not all nurses want to work in a hospital. It's true. Some nurses want to work in clinics, some nurses want to work in home care, and some nurses want to work in our long-term care settings. Hospital work is hard, and I will acknowledge that it is hard, but hospitals generally pay considerably better than those other care settings do. And finally, I want to comment on work environment. This was a study that was done by WalletHub, and I realize WalletHub is not necessarily the most scientific data source. But what they did was they interviewed nurses around the country, and on 20 different metrics, they ranked where's a great place for a nurse to work. Minnesota ranked number 6 on this list, but we ranked number 2 for work environment. So we do have nurses that want to work in hospitals, and they are a good environment for work. So thank you for consideration of my comments. I do believe this bill would be bad for patient care. Thank you.
Thank you for your testimony. Melissa Heising. The next person on my list is Devin Bruce. Welcome to the committee. State your name for the record.
Thank you, Mr. Chair. My name is Melissa Heising, and I'm Legislative Director of the Minnesota AFL-CIO, the state labor federation of more than 1,000 local unions who represent over 300,000 working people in every corner of the state, in nearly every kind of job. All of the unions representing healthcare workers in Minnesota are in support of House File 4200, including AFSCME, MAPE, MNA, SEIU, the Steelworkers, and UFCW. House File 4200 adds protections in labor statute to protect workers from retaliation for requesting a modification to an unsafe patient assignment. As you just heard from the testifiers and is backed up by academic studies, healthcare workers face retaliation for speaking up about their concerns for patient safety. In Minnesota, when working people who provide essential services tell us what they need to do their job safely, we listen. When frontline workers with firsthand knowledge bring us solutions, we listen. There are more nurses in Minnesota than ever before, yet they are leaving the profession due to working conditions that do not allow them to do their job safely. And from what I just heard, hospital management continues to dismiss their concerns and confuses retaliation with accountability. Let's listen to healthcare workers and pass the HEAL Act to put the responsibility for staffing levels that allow for safe patient care where it belongs, on management. Thank you.
Thank you for your testimony. Devin Bruce, and the next person I have is Diana Tosted-Dahmer. Welcome to the committee. State your name for the record.
Thank you, Mr. Chair and members. For the record, my name is Devin Bruce. I am the Legislative Director at the Minnesota Association of Professional Employees, a union representing over 17,000 state professionals across all agencies, boards, and commissions, including our therapeutic and rehabilitation staff at the Minnesota-operated facilities. This bill provides crucial workplace protections for patient care staff who speak up about patient safety concerns in our state-operated facilities. MAPE members work in inherently dangerous conditions, providing therapeutic, psychological, and rehabilitative services to clients at MSOP, at AMRTC, St. Peter Forensics Hospital, and to the folks who are incarcerated in Minnesota's state correctional facilities. Chronic understaffing has only exacerbated these issues. 5 staffers at MSOP Moose Lake were assaulted by patients last May, and 1 patient at St. Peter, where 2 entire units have been closed down due to short staffing, was killed by another patient this past January. These are not jobs that people enter into expecting to have easy assignments. However, when they do have significant concerns around patient safety, they should expect that when they bring these concerns to management, that they won't face hostility or retaliation. such as was the case in the days following the murder of corrections officer Joseph Gom at Stillwater, when psychologists and therapeutic staff were threatened with discipline for refusing to see patients or conduct classes without security personnel nearby. Patient care staff and stronger labor protections when requesting modified work assignments due to patient concerns are crucial to providing direct patient care. Please support House File 4200. Thank you.
Thank you for your testimony. And Diana? Welcome to the committee. State your name for the record.
Yeah, thank you, Chair and committee members. My name is Diana Testa-Damer, and I'm the Legislative Political Director with United Food and Commercial Workers Union 1189. UFCW represents about 3,000 healthcare workers across the state, mostly in long-term care, but we also represent certified nursing assistants in acute care settings in Duluth. I am here to testify in support of House File 4200 as we continue to see staffing in healthcare facilities across the state put patients and workers at risk, and it is time for a legislative fix for the crisis in our hospitals. In healthcare, the workers who provide direct patient care often tend to be primarily women and BIPOC workers. Our workers are vital for Minnesota's healthcare industry and know what patients need as they direct and provide patient care. Yet, when you look at the power structure in healthcare facilities, those who provide direct care are those with the least amount of power. Though the power structure is skewed against these workers and they have little to no say in what staffing looks like, they take the primary responsibility for patient care and must bear the burden, sometimes even losing their jobs if there are issues that result from unsafe staffing. This pressure is only further multiplied when they experience retaliation for stating they are not trained to provide the care they are assigned or cannot physically be in all the places that they need to meet the needs of patients that they are assigned to for that shift. Data shows that BIPOC workers experience higher rates of retaliation than their white peers. The U.S. Equal Opportunity Commission reports that while applicants and employees in all industries experience retaliation, research shows that workers of color are more likely than others to be fired when they report the violations. The fear of economic harm leaves some workers feeling less willing to risk retaliation by challenging workplace violations. The workers who are most intimately connected to ensuring that patients receive quality care and know what patients need are also the most likely to experience retaliation for speaking up when they advocate. Workers' voices need to be protected to improve patient care and fix the crisis in our hospitals. Please vote to support the HEAL Act and help decrease retaliation against those who are fighting for our family members and loved ones in the hospital. Thank you.
Is there anybody else that, from the audience, that needs to speak? Welcome to the committee. Please state your name for the record.
Thank you. My name is Chris Rubish. Chair Nelson, committee members, thank you for the opportunity to testify today. My name is Chris Rubish. I'm a registered nurse and the elected president of the Minnesota Nurses Association. More importantly, I'm one of the thousands of nurses across Minnesota who struggle every day because of the constant pressure of unsafe staffing and the moral injury associated with hospitals prioritizing bottom lines over patient care. Hospital bedside staff are in crisis. We're here today pleading for the real solutions that allow us to have the safety and security we need to do our jobs. Dozens of objective studies prove that appropriate staffing levels in hospitals lead to better patient outcomes and, ironically, actually to more profits. Yet shift after shift, workers appeal to hospital leaders for help with seriously unsafe staffing. And they're often met with indifference at best. Instead of listening to nurses who are saying that in their professional judgment they cannot safely care for an additional patients, hospital management consistently tell nurses to make do. While my own facility has policies attempting to create a culture of speaking up when staff have safety concerns, we've also been encouraged to just say yes when considering our daily assignments. In addition to undermining the publicly facing message of safety, this message is also extremely problematic on many levels. In your materials today, you'll see a story about how one Minnesota hospital chose to put mats on the ground and increase camera surveillance when a nurse and nursing supervisor expressed concerns about staffing levels. Despite appropriately escalating their concerns up the chain of command, the management team at the hospital determined that a few extra mats on the ground was less expensive than even attempting to find more staff. Cameras and mats weren't able to help a patient if they fell to the ground, and neither were the nurses whose patient assignments were already too much. I want to close today by sharing with you what was the worst day of my nursing career. It's the day that I made my one and only medication error. These aren't things that we like to acknowledge have happened, but I hope that by sharing it today, I can show you why staffing levels are so critically important to protecting patients. It was an incredibly busy shift. We were short on nurses. We had no CNAs or assistive personnel to help on the unit. I tried to object to my assignment and state that my clinical judgment made me question if I could safely care for all the patients I was being assigned. I escalated my concerns, and I was told that there was no other option. I had to take the assignment. I've seen what happens to nurses who speak up too often, and I began my shift. Later on that shift, for the only time in my career, I caused a medication error. Thankfully, it was an underdosing of a patient, meaning they got less of the medication than had been ordered. I was able to report the error, administer the rest of the medication, and there was no harm to a patient. But I realized then and there the harsh reality that I knew that I could not safely care for those patients. And it was only by the grace of God and some luck that no one was harmed. I knew that that was on my license and my responsibility, and my manager or my director of nursing, my chief nursing officer, they wouldn't be responsible. I would be. I saw that day that without protections for nurses to be able to object to their assignments when they assess there to be a critically unsafe situation, there will continue to be risks of these types of near misses. Without these protections, healthcare workers will continue to be forced to choose between their obligations under the Nurse Practice Act or the risk of discipline, retaliation, or harassment at work. Please don't leave us behind again. Please allow healthcare workers the protections they need to speak up for patient safety. Please vote yes to moving this bill here today.
Thank you for your testimony. Again, is there anybody else in the audience that needs to speak on this bill? If not, we'll go to discussion. Member questions? Representative Schultz.
My apologies, Mr. Chair. Did we already deal with the amendment?
Yes, we did.
Okay, thank you.
We put the amendment on, yes.
Appreciate it. Thank you. All right, so looking at this bill, number one, thank you for all the testifiers wherever you came from across the state. We appreciate it and the care that you provide across the state and the way that you serve patients. And to Representative Feist, you do an excellent job presenting a bill. And so to begin with that, I want to kind of center us a little bit around Section 5 and how this plays out practically. So let's use an instance that that someone does that a nurse decides that they cannot reasonably deliver care. Can you outline for the committee and for the record what happens for the patient who's in need of care?
Representative Feist.
Yep, thank you. I could talk about it in theory, but I think I'll have an actual nurse come up and provide a scenario. So, and just to be clear, we heard some scenarios where the patient care staff have said, this is a problem, we can't safely care, and hospitals have sent them home. So that's one thing that happens. And then people who, like the one story that I shared where people had been working overnight were forced to then continue on. So that is one example. But I'm just going to see if one of our nurses who are present would like to share an example as well.
Again, state your name.
Chris Rubish, registered nurse. Another section, I believe, in this bill speaks to the fact that the information for calling up the chain of command must be present and must be available to nurses. I know in my own facility that information to call up the chain of command. So, for example, on an overnight shift to the manager on call, then to the administrator on call, and then up to and including the chief nursing officer is not available to me, and I have to go through the management to get that. So oftentimes when I escalate my concern, I'm told, this has already been discussed, this is what you're doing. I don't know if that conversation has happened. I don't know if any additional staff have been called or even asked. And so the liability and responsibility for the care lies on me. And I don't know if legally I have done everything I need to do because I don't know if my supervisors have been notified.
Representative Schultz.
Thank you, Mr. Chair, and to both Mr. Rubish and Representative Feist. As I look at the bill, I think we also need to consider, amidst the concern for our labor force, we need to have the same concern for our patients. I understand that it goes after the emergency circumstances and people who are in need of immediate medical care. I'd like to hear from you, Representative Feist, as to exactly what happens for the patients based upon what you have written here into this bill.
Representative Feist.
Yep, thank you. One preliminary, I'm happy to respond, but I just want to emphasize as well that the goal with this language is to provide labor protections for actions that are already protected under whistleblower law and in fact required under the Nurse Practice Act. So if you have input in terms of like how you're reading this and how it would play out, where you feel like it goes beyond, and I'm just going to quote the laws that prohibit retaliation for when an employee in good faith reports a situation in which the quality of healthcare services provided by a healthcare facility, organization, or healthcare provider violates a standard established by federal or state law or professionally recognized national, clinical, or ethical standard and potentially places the public at risk of harm. That's what we're trying to protect, is that. And so, what happens is that nurses and other patient care staff often just take the assignment, and patients, like you heard from Mr. Rubish, are placed at risk. That is often what happens. Also, as Ryan shared his experience, where basically the overnight patient care staff were forced to continue on and care for those patients, even though they were had not gotten sleep and did not feel capable of doing so safely. And so I guess the answer is, clear from the Department of Health's 2023 Adverse Events Report that more adverse events occur unless we provide these protections.
Mr. Chair, thank you. Representative Feist, I understand the concern, and frankly, I think that around this table we share this concern to ensure that that there are proper staffing levels to treat our patients well. I think that's a very broadly accepted premise. My concern here, and why I'm asking this question and seeking to get definition, is for the patients. What happens to the patients using what you have here in the back half of Section 5 of this bill? What happens to the patients when care is rejected for them?
Representative Feist.
Well, I think I've answered this question. So either the patient care staff who has expressed the concern, if they're a nurse, it's under the Nurse Practice Act, where they're required to express that concern over patient safety. They either accept the assignment and do so against their professional judgment and not in the interest of that patient, or other staff who are equally overburdened and don't feel capable are going to step in and care for that patient.
Mr. Chair, and I really am not trying to belabor this point at all. I'm trying to talk about the future. If this bill is put into law, we have to reckon with how patients will be treated in this circumstance. So I absolutely understand. And if this bill becomes law, the concerns of our nurses, which are certainly very relevant, they will, in essence, be taken care of. What will happen to the patient? That's what I'm trying to get at.
I do have a separate response, and then it looks like Mr. Rubish also has. So the goal with this bill, which is to provide labor protections, and labor laws are always about how we balance power. And so this is empowering workers in a way that the goal is to put the responsibility where it should be on administration that can look at the macro level needs of that facility and proactively ensure that they have sufficient staff so that this doesn't happen. Like, the goal is to not have this happen. Like, nobody wants our patient care staff to regularly show up for work and say there are too many high acuity patients, or I'm not trained to work in an emergency department. Like, nobody wants this to ever happen. Like, the goal is that this bill would pass and then administrators would say we need to be proactive, because there has been a shift in power. It's a labor protection. So the goal is to make this a more of a proactive effort by administration to adequately staff hospitals. And Mr. Rubish, did you have-
Mr. Rubish?
Yes, thank you, Chris Rubish, registered nurse. I think, again, in terms of what would happen to that patient or those patients, the hospital and the hospitals have continually asserted that it is their responsibility to staff and schedule for patient care. And so what we're seeking is for them to staff and schedule for patient care. And so if there's a concern, the nurses, in my job description, is to give care, and administration's job is to provide resources, infrastructure, and other staff to support that work. And so we'd be seeking the hospitals to call in the other staff to go through the usual processes that they control. And if it would be agreeable, I think we'd certainly, help with that effort. But ultimately, we're looking for the hospitals to find and bring in those additional staff to help us care.
Representative Schultz?
Yeah, Mr. Chair, I'd like to ask that same question that I've been asking here to Mr. Carlin. He provided some excellent testimony earlier, and I'd like to hear his perspective on this same question.
Mr. Carlin,
Mr. Chair,
you understand the question?
I do, yes. Mr. Chair, under these circumstances, our concern is that these patients would be held in the emergency department. And in the emergency department, under federal law, EMTALA law, we would be required to accept all patients, which we do, which means our emergency departments could be continuously overrun. I think what is of extreme concern as we think about what we do as hospital systems, I'm coming to you as a leader who has worked across 2 health systems in Minnesota, which would represent over 20 hospitals in Minnesota. We have in place processes that we work through to ensure that we are trying to match our staffing plan with the number of patients that we have. And there are both projections that we use to try to meet that, as well as in the moment adjustments that we're making to try to meet that. I can tell you that in the hospitals that I've worked at, what I see under these terms is a nurse comes forward and says, I'm concerned about my assignment. This is really difficult for me to do. They may talk to their charge nurse, they talk to their nurse manager, they talk to the nursing supervisor, and they try to work through a plan. They say, what can we do? As the chief nursing officer, I've been involved in those discussions. Sometimes what we do is we may say, emergency department, we need to pause on this unit for a moment because this unit is really overwhelmed and we need to get them caught up. And our emergency departments work with us to do that. These are the things that happen every day in our hospitals right now. Under the example that's given, it is extremely concerning to think how this law could be used in a manner in which an entire staff on a unit would say, we don't agree with the ratio on our unit, and therefore there's going to be an organized effort to refuse patients every day as a group because we feel it is unsafe. The bar in this law of the subjective and objective in good faith and reasonable would be the bar that this would be held to. It is extremely concerning to think what that accountability level simply becomes, I would just need to say, I don't think it's safe, and I'm not willing to talk about it today. I'm going to need representation. This could halt admissions in a hospital. This could halt admissions on a unit with no ability for us to continue to provide care in a safe manner. Thank you.
Representative Feist?
Yep, thank you. So just to be clear, the process laid out in this bill requires any patient care staff who actually is concerned to explain themselves. So they also need to show that it's reasonable. So if, and I don't think this happens, but say a nurse shows up every Friday that they're scheduled to work and is like, ooh, that's unsafe. Like they need to be reasonable. They need to explain themselves. There's nothing in this bill that says that all the nurses can conspire to not care for patients. And I think it's pretty, and I think we all agree that the people who go into this field of caring for patients do so because they're very passionate and committed to their work. So I think it's a little bit insulting to them to think that they would use this to not do the job that they love and chose to do with their lives.
I'm going to move on to Representative Greenman. You had a question?
Thank you, Mr. Chair, and thank you, Representative Feist, for bringing this bill. My sister is a nurse, and just yesterday, I didn't actually know this bill was up, but she texted me like she often does. She's also a constituent, so I have to respond to her text. About concerns that she and some of her colleagues from nursing school have because of what's happening at Mercy and Unity and Alina. And I feel like she reaches out to me every week about something else that's happening, decisions that are being made at the executive level, for whatever reason, units that are being closed, things that are being overstaffed, and has no power. I think that there's a feeling of to actually weigh in for these decisions to make sure that they're made in a way that's good for patients, in a way that's made for the people who are caring for patients. And so the amount of, and I just get this from her, the amount of frustration, the amount of powerlessness, I think, that people feel that I know her and her colleagues, and we have heard today. So I really appreciate this because I think putting everybody, frankly, in the hospital in a position to be focused on what is best and safe for patients and the people who care for them is really important. I actually have a question, and I guess, Mr. Carlin, can I ask you, because it's sort of from a lens of, we heard from Mr. Rubish about, and I know you're also a nurse, so I just wanted to get your take, about having a situation that this is meant to avoid, which is an unsafe situation that led to an accident, right? And we heard about that. I'm wondering, sort of as a nurse, if you are in that situation and you don't have sort of the protections, you're in an unsafe assignment you find unsafe, say it's understaffed, and God forbid there's an accident, right? Someone and they die, and someone dies. What happens to you as a nurse in that situation in terms of your license and liability and that kind of stuff?
Absolutely. I think
Mr.
it's
Oh, no, not
Or Mr. Carlin, I'm sorry.
Mr. Chair, I think that's an excellent question. So I think one thing to think about is the principles and organizations of just culture. And in the principles of just culture, we would follow under any of these circumstances. Again, and just culture has been something that was developed in the airline industry that has been widely adopted in healthcare. Many organizations would look to these algorithms to help determine, was it a reckless behavior that resulted in the error? Or was it truly human error? And under those circumstances of human error, again, speaking to 20 hospital or two health systems encompassing 20 hospitals in the state of Minnesota, I can tell you working through these situations when they have happened, we would work through that, and almost unanimously, we are going to move forward with supporting the employee, and ultimately the liability may lie with the organization under those circumstances. And then the other part of that I would say is looking at the Minnesota Vulnerable Adult Act. It specifically has protections for healthcare workers who caring for anyone who's a vulnerable adult, which would be any hospitalized patient who makes an error in good faith, that person would be protected from civil and criminal liability.
Representative Greenman.
Thank you, Mr. Chair. So are you, just so that I'm clear, and I apologize as a lawyer asking this, but so if in that hypothetical where somebody has a situation they feel is unsafe, maybe they say it's unsafe, they continue to do it, they make a medical error, that person dies, that the nurse will not be, could not be sued, or sort of how would that work in terms of you make that, are you potentially liable for getting sued? Sorry, I'm asking specifically about the nurse.
Mr. Carlin.
I would say under those circumstances, that patient who is hospitalized would be considered a vulnerable adult. And as my understanding of the Minnesota Vulnerable Adult Act, it would apply to that situation, and any person who makes an error under that circumstances would be determined that if that error was made and the person followed the protocols that were involved and an error occurred for the patient, that person could not be held liable civilly or criminally.
President Greenman.
Thank you.
Wrap up, 'cause I got more questions.
Oh, yep, I appreciate that. And when you say the conditions, so even if those conditions were unsafe, the nurse didn't have the ability to change them. And I will, since I think this is my last question, that they wouldn't be subject to liability. And is there a possibility that their license could be impacted? And here's why. Here's why I think as lawmakers this matters. We wrote the law that charges nurses with the requirement that they consider and have the responsibility to protect patients. And so I think what this bill does is say we are going to charge nurses with that responsibility, and in order to be able to do that, we're also going to protect nurses from the consequences of things that they don't have control over. We as lawmakers, I think, shouldn't put nurses in a position where we're charging them with something that they then can't do and then don't have rules to protect them. So that's sort of where I'm coming from.
Mr. Carlin. Anyway, next person on my list of questioners is Representative McDonald.
Mr. Chair, thank you. I think it's safe to say that everyone in the room can say they have a mother, a father, a brother, a sister, a nephew, a niece, a neighbor, a friend who is a nurse. I certainly am in that camp. Probably all of the above. Let's see, sister, niece, friend, cousin, brother, yeah, several. And we're most part on the nurse's side, right? Not the big hospitals and stuff. But we have to have an equal balance with hospitals who, of course, have to, I suppose, be responsible in their administration and make sure they are viable and open for business for our patients. So I think, like Representative Schultz mentioned, that it's a very important topic, and we're all sympathetic to the testimony that we've heard. And actually, I was just on the phone to my cousin, Billy McDonald from Watertown, whose wife is a nurse, and he brought up some very good points in favor of this, perhaps, legislation, but I had some questions as well. So in some of the testimony, the Representative Feist that you brought down, and the nurses who I certainly will not upset, because I might be at their bedside someday. But it is all about patient care and the safety of a patient. Some said they don't want to risk harming the patient for the fear of getting a scarlet letter, or a patient could get hurt. And that certainly makes sense, and we don't want that to happen, right? Because it is all about patient care. But our nurses, who are bold, beautiful, strong, steady, have a responsibility, and I know you all know this, to go up and above the call of duty. But it's also the hospitals have the responsibility as well, not to completely overwhelm them. We don't know what that looks like, right? Maybe you do with your bill, Representative Feist. I've heard some concerns for and against it. But if it is all indeed about patient care, and I believe it is it better for a nurse to risk, or is it, let me restate this. It seems to me if it is about patient care, not harming the patient, is it better for that nurse to at least go to that patient to see if they can help and assist than completely deny because they're overwhelmed? Because if they deny and say, I can't take this patient, I'm overwhelmed, of course, they got to give written permission or oral permission and have the charge nurse give permission of that. Isn't that patient then in need of care and in a risking of future harm?
Representative Feist.
Yep, thank you. Thank you for the question. I don't believe that we should have to choose between unsafe patient care that places us in danger and no care. The goal of this bill is to create a systemic level change and a shift in incentives and in power to ensure that hospitals who have the most control over staffing levels proactively ensure that there is safe staffing. We've heard examples here about how unsafe staffing levels have directly led to patient harm. And under the Nurse Practice Act, harm isn't even required for a nurse's license to be on the line if they accept an unsafe patient assignment. So I believe that's a false choice. The purpose of this bill is to create a systemic approach to an issue that is nationwide and is a trend that we've seen over many decades where hospitals are decreasing staffing levels and adverse events have increased as a result.
And members, just so you know, we're going to take a vote on this at quarter after, because we have another bill we have to do this afternoon. So Representative McDonald.
Yeah, thank you, Representative Feist. Two more questions, I think, at this juncture. One is regarding the language of your bill on 4.18 down to 4.23, or actually 4.19, really. And it says, under 2, if they fails to accept an assignment of one or more additional patients. Under your bill, is it a possibility that a nurse would request not to care for 3 or 4 or 5 patients? At what's number? Because your bill says 1 or more. So I'm just curious, what if they're so overwhelmed that they say, well, I can't take care of 2, 3, and 4?
Representative Feist.
So thank you for the question. The way it works is the nurses or patient care staff would ask for a modified assignment. So the specifics would depend on the situation. So does it have to do with the acuity levels of all of the patients, of some of the patients? Does it have to do with their level of experience? That really impacts how many patients or what types of patients they can care for. And it also has to do with their specific type of training. So it depends on the unit. It depends on what is being asked of that nurse. So, and again, just to reiterate, the goal here is to protect under labor law actions that are already protected under whistleblower law and under the Nurse Practice Act. And so if there's specific line edits, you don't have to do it like in real time, but I'm very open to those because we're not trying to encourage new behavior. We're trying to protect things that these patient care staff are already required to do and protected for under whistleblower law.
Representative McDonald.
Thank you, Mr. Chair. Question then regarding, maybe it's for you or Mr. Danush, was it, did I pronounce that correctly? Rubish. I knew there was an ish in there. I-C-H or I-S-H. About collective bargaining, though, isn't this something that the union and the nurses should be able to collective bargain with the hospitals in the first place? They have such a strong nurses union that are by your, behind you and beside you.
Representative Feist.
Yep. Thank you. So this bill covers a broader range of patient care staff, so not just nurses. And not all nurses in the state of Minnesota have protections or work in a facility that's represented by a union. The goal here is to ensure that wherever you are a patient in Minnesota or a resident in a high acute care setting, that you have these protections. It is a labor bill, but it is ultimately about us. It's about patients. And so we don't want to provide these incentives only in facilities that have labor representation. We want all acute care settings in the state of Minnesota to have these same protections.
Representative McDonald.
Well, thank you, Mr. Chair. Representative Feist, I'm not sure if I heard the answer, but it's not, mission critical that I understand it completely. But certainly it was important that we know that through collective bargaining that the union can negotiate with the hospitals to begin with, and not necessarily having this language in the bill passed for the fear of continuing patient care not being taken care of because of a nurse can deny taking care of the patient for whatever reason. I'm not so concerned about a nurse denying a patient because of race, creed, color, or sexuality, or if they're Irish or Polish or whatever. I hope that's not, and we already have laws against that to begin with, both for the nurses and the patients. So, and then lastly, I think I'm glad that Ms. Krinke did come up and testify of the great hospitals that we have and the great care that we have in Minnesota. We're ranked high in the United States. Some of the testimony was disturbing. I hope that's not true. I'm skeptical that a charge nurse would dismiss a nurse not for retaliation when there's patients galore. Say, well, go home. We got patients galore, but go home. That seems skeptical, but I'm not there. But I'm glad that Ms. Krinke did state, and at least state for the record, that we do have, we're not perfect, but we do have a great hospital system with great nurses and doctors in patient care. And the statistics do validate it, because I did Google it, and we are ranked high, thanks be to God.
The next question I have is Representative Jordan.
Thank you, Mr. Chair. I did have a number of questions, but I can be brief. I guess I have heard from constituents who are nurses in hospitals who have been there when there have been unsafe staffing levels, and they've talked about it and then been disciplined or sent home. And I really fail to see how that helps with our staffing levels when when nurses are saying these staffing levels are not safe for patients, and then as a result of the retaliation, the staffing levels are further diminished. I've heard personally from constituents that have had this happen, and what they say, and nurses know this because their working conditions are the conditions that we all have to heal, to deliver babies, to make sure our kid gets their arm in a cast. Those are nurses' working conditions, but those are also our healing conditions. And so nurses are advocating for this, but it's not enough to just, be compensated for their care. Like, nurses need to have a voice on the job. And it's also my understanding, and maybe Representative Feist, you can confirm this, is there a shortage of people with nursing degrees or nursing licenses in the state of Minnesota?
Representative Feist.
No, there is not. I believe that the stat is that there are more nurses right now than there ever have been in the state of Minnesota.
Representative Jordan.
Thank you, Mr. Chair. And then Representative Feist, one last question, but then why are we facing shortages of nurses actually helping patients right now?
Representative Feist.
It was over 2,403 nurses have said in the recent survey that they left the bedside specifically because of unsafe staffing.
Representative Mecklen.
Thank you, Mr. Chair. That was part of my question as to because somebody did testify we have more nurses than ever, but a number of times I'm hearing that we have a shortage. And I think from 21, 22 years, there was a lot of nurses that left the industry due to mandates. I talked to many of them. So you're now saying that we have an abundance, but we don't have enough to do all this. You mentioned that this is about patient care, because not all facilities have protections, as you put it. Twice you made reference to the patient care. But I think I'm not sure, but this is about protecting the nurse, not the patient, because the nurse is saying they don't want to deal with this particular patient. So is it patient care, or is it the protection for the staff that feels uncomfortable would be one part of it. But the other part that I'm really curious, what kind of patient creates, I understand if you're not trained for that type of care, but it sounds like there's times where a patient may be, you may feel threatened or something. Other things. What other things would be a reason to invoke this? What's changed over the years? Where is this coming from? I guess is a question that I have for you.
It's
Representative Feist.
a lot of questions. So for your first question, is this about the patient care staff or is it about the patient? It's about both. And I guess it relates to your second question. Like, what we're trying to do here is protect these experts in care when they are speaking up to management and expressing deep concerns about the safety of a patient assignment. So I was just going through my paperwork. Sorry to keep quoting this at you, but it really comes back to what type of behavior we're trying to support and encourage in healthcare settings. And that is, we want people to speak up without fear of retaliation when they have concern about the safety of a patient assignment. So I was, forgive me, I can't remember your exact wording, but you talked about just refusing, rejecting, but that's not what this is about. Nurses and patient care staff want to care. They want to do their job. They love their jobs. They just want to ensure that they're doing it safely. And so, yeah, I think I'll leave it at that.
Representative Mecklen.
Thank you, Mr. Chair. Perhaps Mary Krinke could answer that question as far as staffing levels because I'm hearing conflicting stories, and I'm trying to understand where all this is right now.
Sure, Mary agrees with.
Welcome back to the committee, and Ms. Krinke, and did you get the hear the question?
I think I got it. Thank you, Mr. Chairman and Representative. The Department of Employment and Economic Development deed will tell you that there's about 5,600 open nursing positions across the state. About half of those are from hospitals seeking additional nurses to be on our staff. The others are for long-term care clinics and other care settings. So yes, there's still a nursing shortage in Minnesota as across the country. And I think it's also important to recognize that some of this is going to be based on demographics and just the fact that we have more elderly people who need care and we have fewer workers entering the workforce. So yes, we are constrained by not having enough nurses in Minnesota, as are most states.
Representative Mecklen.
This is my last thing. So, and thank you, Mr. Chair. I find it interesting, you've said repeatedly that there's, plenty of laws that already protect all this, and we're doing this. And I tried to bring forward an enhanced whistleblower protection amendment a few years back. I was told it all exists. This is not needed. It was a different industry, but failure in that industry has very, very deadly consequences as well. And it was because those particular employees, which I would say are pretty much all union, don't feel the ability to come forward without retaliation. And quite frankly, I was fought heavily on it. It was simply just shot down. But because the laws already exist, all those protections are there. And so I guess I'm really, because now I'm hearing that there is a shortage. I know that I personally in my district, many people left the industry due to the mandates. They absolutely love the job, but they were stuck to their beliefs. And now that seems to not be an issue anymore. I've even talked to the local director of our nearest facility, which is not small, and they've moved on from that. But yet these people are not being brought back in. There's grant programs to offer different incentives to get into schooling for this. There's compromise right now on should we allow other outstate workers to accept their licensing, but yet you're telling me we're flush with nurses. So I'm really confused by all this, but I know we're running out of time, so I'll leave it there.
Representative McDonald, do you want to wrap up?
Mr. Chair, thank you. First of all, I want to thank you and commend you on the length of time that you've given us, all of us, to discuss the bill, the pros and cons, the goods, the bad, and the not so ugly, because it's not that. So we appreciate that as for certainly. But just lastly, I think, no other care can deny a patient in the care industry, as far as I'm aware in my knowledge of this bill and the system. We did see this last year, so I have somewhat knowledge on it as well. But so no other care can deny a patient. So I don't know if this is the best idea or best policy. It's yet to be proven, right? Just doesn't seem to be good. That said, there has to be a better, prudent alternative. And I hope that the hospitals are listening, and the unions certainly are. Seems to be there would be a better approach to this than denying a nurse who loves her job and loves taking care of the patients. That's why they do that, that they could deny a patient. It just doesn't seem like it's a very good idea. But there has to be a better solution, Representative Feist, and certainly I think the people in the room have heard the concerns. I think both parties are responsible for making sure that our nurses are getting the support they need and that our patients, top priority, are getting the care they need. So with that said, Mr. Chair, thank you.
With that, Representative Feist, if you want to quickly wrap up.
Quickly, I've got like a 5-part. Okay, I'll be quick. Just want to emphasize that whistleblower, what we are trying to protect here is the same type of activity that is protected under whistleblower law. The reason that we need labor protections is because those protections, as you've heard, they don't work in the moment to protect patients in the way that we need them to. I also just wanted to mention that we heard some testimony that hospitals stand by nurses when they are brought up under the licensure board for failure to do their professional duty, and that is simply not true, and I wanted to refute that. Also, I've learned a random amount of things about the Vulnerable Adult Act lately for another bill, and I do not believe that it applies in any way to the scenario with respect to the provision of care and the protections it provides. That is just a random tidbit that I know from another bill. And then someone mentioned providing equal balance between patient care staff and management, and I don't think that, right now, the balance is very much, and as it typically is in any workplace setting, management has most of the power. The goal here is to shift the power somewhat in this small, limited way to protect patients. And lastly, I just want to leave with this. There are lots of nurses in the state of Minnesota. It is true, but they don't want to work in these settings. And the reason they say that they don't want to work in these settings is because of this unsafe staffing. And it's become chronic and it is increasing. And we need to do something about it. And I just reiterate that if people have input for me on how we can ensure that this language achieves its goal, I'm very open to that input. So thank you.
And the members, I hear that, and members in the audience, I hear that. If we, as this moves forward, that they continue to work on it, and if Representative Feist is willing to continue to work on it. And with that, I'll renew my motion that House File 4200, as amended, be re-referred to Ways and Means. All those in favor say aye.
Aye.
Opposed? No. The ayes have it. Bill's referred. Thank you, Representative Feist. The next bill we have on our agenda is House File 4286 for Representative Berg, and I understand this is going to be re-referred to the Judiciary, Finance, and Civil Law Committee. So, Representative Berg. And you guys be quiet as you leave so we can continue on. Thank you. Representative Berg, you want to make the motion? This bill is going to Judiciary, Finance, and Civil Law.
Yes, thank you, Mr. Chair. I make that motion.
Representative Berg moves the House File 4286 be re-referred to the Judiciary, Finance, and Civil Law Committee. And you have an amendment, I see.
Yes, I do, Mr. Chair.
Briefly explain your amendment and move your amendment.
Yes, I would like to move my amendment, the A3 amendment, to get the bill in the order in which I prefer.
And do you want to briefly explain what this does?
I do. Thank you, Mr. Chair. Minnesota has two primary statutes that cover the application of our prevailing wage laws. The first is 177.42, which states that projects funded in whole or in part by state funds must pay the prevailing wage. The second is 116J.871, which states, among other things, that local projects that receive a reduction credit or abatement of a tax assessed under Chapter 297A must pay prevailing wage if it is for the economic development purposes. What is missing, or at least unclear, in both of these statutes is the application of prevailing wage to local government projects that receive an exemption from the sales tax on construction materials. This amendment will ensure that these projects are covered by prevailing wage in a way that is consistent with similar projects that get state bonding or tax credits for economic development purposes.
So members, any questions of the amendment?
Mr. Chair.
Representative Schultz.
Thank you, Mr. Chair, and Representative Berg, I think you did a really nice job kind of summing up what this amendment and this change does, which is quite significant, and so I don't want to dismiss the importance of this. As you know, and I've voted for additional prevailing wage standards in this committee before. I wanted to just ask a question, and it may be for you, Representative Berg, it might also be for House Research, but at the end of line 2.1, what would be the definitions around or special law?
Ms. James, I think it's probably best for directed at you.
Thank you, Mr. Chair, Representative Schultz. So I'll just start by saying the tax area is not my area of expertise, but I have talked to a colleague about this amendment. In my understanding, I'm just going to look at one reference so I can give you the correct information. So a majority of local government projects wouldn't fall under the statutory exemption under 297A. And so the way that the localities would be able to get the sales tax exemption is through a special law. And so I understand that there's any number of these in special law each year that would allow a local government to get the sales tax exemption for construction materials.
Representative Schultz.
Thank you, Mr. Chair, and I just want to just note this for the record that making this change does have some implications for local municipalities, school districts, and in doing so, the result will be that when a project comes to be and there's prevailing wage, the cost for said project will be higher, which could, depending upon the project, shift whether the cost, which would be changed from the reduction in the sales tax. So I just want to make that for the record, and thank Representative Berg for bringing it forward.
And Representative Schultz, most of these construction projects are done on a bid basis, and low bid is who gets the job, and whether they have to pay prevailing wage or not on many construction projects, but even non-union or merit shop construction firms often get those, but then when they get those, they have to pay the prevailing wage in the area. So it doesn't affect the price because these are all low bid projects, and that's how they have to go. But anyway, we can have that argument another day.
I look forward to continuing to learn from you through the remainder of these next few months. Thank you for your expertise.
Any further questions on the amendment? If not, all in favor of the...
Mr. Chair.
Representative McDonald?
Yeah, quick question, Mr. Chair. Representative Berg, on your amendment, is there anything about a reasonable time, what that looks like? Oh, are we on the wrong amendment? Well, in that case, Mr. Chair, I retract my statement, and I'll wait for the question for Myers.
Again, we're on the A3 amendment. All those in favor of the A3 amendment to put the bill in the condition the author wants, please say aye. Aye. Opposed? The ayes have it. The amendment's approved. The A2 amendment, is that your amendment or? Okay. Why don't we do like we normally do, explain the bill and go from there. And then we'll do the amendment after we have discussion. Representative Berg, explain your bill.
Thank you, Mr. Chair. So House File 4286 is the Department of Labor's industry policy and technical bill for labor standards. The bill makes a series of updates and clarifications in areas like child labor, pregnancy accommodations, and parental leave, the Nursing Home Workforce Standards Board, and others. The Labor Standards Division within DLI works to ensure workers are paid correctly and workplace rights and responsibilities are enforced for all workers and help employers prevent employment law violations before they occur. Labor Standards also answers wage and hour questions with breaks, minimum wage, overtime, pregnant workers and new parents' rights, prevailing wage, and wage theft. The goal is to protect the rights of workers as well as to educate employers and employees about their rights and responsibilities under Minnesota employment law. I think at this point, I will hand the walkthrough over to the testifier from the department.
And Ms. Jessica Groves from the Labor Department, Standards in the Department of Labor. Welcome to the committee. State your name for the record and proceed.
Thank you, Chair and members. My name is Jessica Gross, and I'm the Director of the Labor Standards Division at the Department of Labor and Industry. Thank you for the opportunity to testify in support of House File 4286, the Labor Standards Policy and Technical Bill. The Division of Labor Standards exists to protect the rights of workers and educate employers and employees about their rights under Minnesota employment laws. We ensure workers are paid correctly and workplace rights and responsibilities are enforced for all workers, and help employers prevent employment law violations before they occur. Labor Standards also answers wage and hour questions about breaks, minimum wage, overtime, prevailing wage, earned sick and safe time, wage theft, and other working conditions. This bill makes several changes throughout Chapter 177, 181, and 181A to help the division fulfill this mission. First, Section 1 classifies the identities of complainants as private data when individuals complain to DLI regarding alleged violations of Chapter 177, 181, 181A, and certain parts of Chapter 179. Section 2 allows the Commissioner to determine the manner in which records are produced when the Commissioner demands records. Section 3 gives the Commissioner authority to enforce existing statutes, providing that wages must be paid every 15 days and prohibiting false statements as inducement to entering employment. Section 4 clarifies that when the Commissioner issues a compliance order for violations of retaliation provisions, the Commissioner may order reinstatement and any other appropriate relief. Section 5 updates record-keeping requirements to require employers to keep records of earning statements for 3 years. Section 6 clarifies the definition of project in the prevailing wage statute. The change is meant to help clarify the scope of work that triggers prevailing wage under the current definition so that employers are better informed of when prevailing wage attaches to their projects. Section 7 updates voting requirements on the Nursing Home Workforce Standards Board to require that any measure passed by the board must have the support of 2 out of 3 commissioner members. Sections 8 through 10 align continuation of benefits language in the pregnancy accommodations and pregnancy and parenting leave sections of the Women's Economic Security Act with the paid family and medical leave law. And finally, sections 11 through 14 make changes and clarifications to child labor laws, including clarifying the existing penalty structure, adding retaliation protections, and adding liquidated damages for minors working in hazardous occupations. I want to conclude by highlighting the importance of these child labor provisions in a time when child labor violations are rising across the country. Retaliation protections are necessary to ensure employees can file complaints and participate in investigations without fear of retaliation from their employer. Adding a liquidated damages provision would provide impacted minor children with a monetary remedy when employers require them to perform hazardous work in violation of the law and to the detriment of their safety. It would also deter employers from employing minor children to perform this hazardous work. Thank you for the opportunity to testify in support of House File 4286.
Thank you for your testimony. And if you want to stay there for questions, and quickly, is there anyone else in the audience that needs to speak for or against this bill? If not, we'll go to discussion. Representative Schultz, I see you got the other amendment?
Yes, I do.
You want to move the amendment and explain it?
I do. Thank you, Mr. Chair. I do move the A2 amendment, and this makes hopefully a simple change, and Representative Berg and the department, I'm hoping that this can be something that is friendly and amenable to you. You know, we do move at rapid pace around here, and thus this isn't meant to do any significant changes to the bill except for to provide a little bit more humility, especially for employers and small business owners in particular, that they have just a reasonable period of time to respond that is proportional to the volume of the records requested under lines 2.5 and 2.6 of the underlying bill. So that is the A2 amendment, and I would ask for your support.
And Ms. Groves.
Thank you. DLI does not support this amendment. Currently, under Minnesota Statute 177.30, employers must maintain records for 3 years and make those records readily available. DLI also has the authority to demand that these records be provided within 72 hours. At times, we do demand records within 72 hours. We never demand records to be provided in less than 72 hours, other than in instances when we are performing on-site investigations and may collect and copy records on-site.
Representative Schultz.
Thank you, Mr. Chair, and I still would request your support for this on a bipartisan basis, because all this is language before us to provide humility and to ensure that the time expected, the reasonable time expected for employers is simply proportional to the volume of records requested. It's really very simple, and I would ask that the department reconsider their position on this and ask for member support of this amendment, because I think it's really relatively simple and could help the flow of business here in Minnesota.
Representative Myers.
Thank you, Chair. Yeah, I would be hopeful that the department would look at this as, you know, I represent a lot of small businesses and large businesses, and, you know, the departments they have and the time that they need to respond to some of these can really vary. I mean, either which way, we're just providing some reasonable alternative or solution. And I think if we can't even, again, talking about humility a little bit, have the humility of being able to address those situations or understand, reviewing a lot of these businesses of all different shapes and sizes. Again, a one-size-fits-all doesn't work.
Representative McDonald.
Thank you, Mr. Chair. Representative Berg, I would just hope, or at least have you consider accepting Representative Schultz's amendment. The Department of Labor, from my observation over the number of years I've been here, and at least particularly with labor and industry, especially under Commissioner Blissenbach, is that they have been, God bless you, and God bless you. He's been sneezing a lot. I hope you don't have a cold over there, Representative Wolgamott.
Seasonal allergies, Representative McDonald. Thank you.
Yeah, sorry, thank you for the indulgence of that delay. But anyway, under Commissioner Blissenbach, Ms. Gross, she has administered and demonstrated compliance and compassion and understanding and leniency, which I hope that the Department of Labor will continue to do so when dealing with employers, businesses small and large. And this just validates their commitment to be helpful for businesses while still, interpreting the law and making sure that employers are in compliance with the law. But this particular amendment just has a reasonable amount of time. And again, I'll just reiterate, Mr. Chair, that the Department of Labor has already distributed or demonstrated some leniency, compassion, and some help for our local businesses. So I hope you take that into consideration, that this is well in line with the Department of Labor and Industries, reasonable methods in distributing and advancing state statute when some businesses are not in compliance.
Representative Berg.
Thank you, Mr. Chair, and thank you all for your remarks. We are going to recommend not to accept this. I think 72 hours is a reasonable time frame. I'm a little confused what humility has to do with it, but my recommendation is that we do not accept this amendment. Thank you.
Representative Schultz.
Yeah, thank you, Mr. Chair. And for our DLI staff here, I think just to correct the record, we're working from statute 177.27 is what we're working from, just to correct what you stated here. This is pretty simple. Let's do it. Let's help these folks, especially with the proportional amount of volume, especially for folks like small businesses. Thank you.
Seeing no further questions, all in favor of the A2 amendment, please say aye.
Aye.
Opposed?
No.
Yeah, the motion does not pass. The amendment's not adopted. I would suggest, Representative Schultz, that you continue working with DLI and the author as this moves forward to maybe tighten up that language. I think reasonable period and proportional to volume.
Thank you, Mr. Chair, for offering those kind words of support, because it kind of falls in line with the previous bill. So thanks.
Yep, anyway. To the bill, and if you quickly, any further questions on the bill? Representative Myers.
Yeah, thank you, Chair. For the testifier, if you could look at section 1.9 through 1.14. Question for you is the only data that's going to be private is the identity, and the rest of the information is going to be released?
Ms. Groves.
Yes, my understanding is that this subdivision relates to the identity of complainants. So any data that identifies an individual who has complained to DLI regarding one of these chapters would be classified as private data.
Representative Myers.
Okay, and thank you for that. So a follow-up question to that, does that mean is it their identity blacked out and the rest of the information is typically provided to who's requesting it?
Ms. Groves.
Thank you. Yes, so basically, we would need to look at other applicable provisions of the Minnesota Government Data Practices Act when providing information. But in terms of this subdivision, what would be redacted would be data that would identify an individual complaining.
Representative Myers.
Thank you, Chair. And then one just follow-up question. In operations of the work that you guys do, what due diligence is done when complaints are made to ensure they're not frivolous? I'm just interested from your perspective, if you get complaints and you can see that it's an employee, maybe that's information that shows, okay, there's some substance there versus just a person that has no connections. I'm just wondering if there's any due diligence done from your guys' end.
Ms. Groves.
Thank you for the question. There's substantial due diligence. So typically when we embark on an investigation, we'll speak with the complainant. We may speak with other impacted workers, other witnesses. We'll gather evidence that workers and witnesses have available, and we'll also request records and information from the employer in order to determine if violations have occurred of the laws that are under our jurisdiction.
Representative Myers.
Final question. And so what percentage of complaints are kicked out for frivolous before you have to follow up with a employer?
Ms. Groves.
I don't have that information available today.
Okay.
Representative Schultz, quickly. We're going to go over time here. And
Thank you, and again, thank you to you for this. When I'm looking at this bill, and I just kind of honed in on Section 7 here a little bit, especially considering we just dealt with this last year. I'm gonna just cast a little bit of concern, and maybe we can hear number one from the department as to why this is a good idea. But just ultimately, and I'm not going to speak after they speak, but 2 of the 5 affirmative votes must be cast by commissioner members of the new board. And I guess I'm seeking to understand why we might be doing that.
Ms. Groves. I think this is an existing board, but not a new board. Ms. Groves.
Correct.
Thank you for your question. Section 7 relates to an amendment to ensure good governance.
Representative Schultz.
Okay, I would just argue that good governance, in my opinion, doesn't necessarily mean that 2/3 of the commissioners have to agree in order for something to move through this board. That's my only comment. Thank you, Mr. Chair.
Any further questions? If not, Representative Berg, you want to renew your motion?
Thank you. Yes, I do renew my motion that House File 4286, as amended, be re-referred to Judiciary, Finance, and Civil Law Committee.
Motion's been made to refer 4286 to Judiciary, Finance, and Civil Law. All in favor, say aye. Aye. Opposed?
No.
The ayes have it. Bill's re-referred. Thank you. And members, with that, nothing else before our committee. We're adjourned.